Mrs. Opeku is a 48-year-old who works as an office secretary and comes to the hospital with a progressive history of swelling and pain on the left leg for the last 3 days, which started 12 hours after a road trip. Okay, she denies of any history of recent infection or trauma, and then she doesn't have any chest pain or breathlessness or even palpitations. On the past medical and surgical history, there is no, she reports to have been using oral contraceptives for the last 3 years. In her last clinic, she was told that her BMI is 31, so she needs to shed a little bit of weight, and there is no history of previous DVT or clotting disorder in the family. You go ahead and look at the vitals. The vitals are stable. She is a febrile with a heart rate of 92 beats per minute. And then the blood pressure is 128/80 millimeters of mercury and a saturation of 98% in room air. You go ahead and do the local examination, and there is swelling on the left leg extending from the ankle to the thigh. And then there is calf tenderness, which is warm, and also a bit of erythema. And then the calf circumference is around 4 centimeters larger than the right leg. And then the Homan sign is positive. What do you think this patient is suffering from? Hello, my name is Joseph Tsuma, always your favorite doctor. And when you see me here, you know it is Matters Health. I'm here to bring you trusted health information that wherever you are. And you can follow us for simple, updated, and practical, reliable insights to keep you and your family healthy. You can subscribe to our YouTube channel at Doctor on Wheels. You can also follow me on TikTok at Dr. Etsuma. So today I want us to discuss deep venous thrombosis. But before we dive into today's topic, I want us to listen to some words of wisdom from Ezekiel chapter 37 verse 5. And the Bible says, "Thus says the Lord God to these bones, Behold, I will cause breath to enter you, and you shall live." And just a bit of context here, Ezekiel is taken to a valley that is full of bones. And God asked Ezekiel whether these bones can actually come back to life. And Ezekiel tells God that God knows better. And God tells Ezekiel to prophesy to these bones. And when he did that, actually the bones were able to resurrect. And flesh came into these bones, and they became a very big army. What can we learn from this case? We can learn that God can change the most desperate situation into a beautiful and a wonderful ending. There's something that you've been trusting God for, a very desperate situation, and you feel like God cannot change it. God can actually change that desperate situation that looks like bones, okay? And He can actually transform it to the most beautiful and wonderful ending that people will be able to end. So keep the faith, okay? Keep trusting in the Lord, because God will definitely come through for you. So let us dive into today's topic. So what is deep venous thrombosis? So DVT or DVT. So it is part of the venous thromboembolism spectrum. Now, deep venous thrombosis basically is clot of blood in the veins, okay? In the deep veins, and especially the veins of the legs, okay? But also of the lower limb, but also they can happen in the veins of the upper limb, okay? And this one can actually lead to what we call pulmonary thromboembolism, especially if that clot dislodges, it goes to the heart, and the heart pumps that clot into the lungs. Now, around 1 to 2 people will be affected out of 1,000 adults. So if you have around 1,000 adults, around 1 to 2 will be affected annually, okay? And it's more common in the elderly, okay? So older women, okay, or basically adults, okay? The second thing, it's more common in patients who have been hospitalized, pregnant women, and people who are suffering from cancer. And it is one of the leading causes of preventable hospital deaths. Okay. Now, What are some of the risk factors? So we have what we call the virtuous triad. So these are three aspects that always must be present for DVT to take place or for DVT to happen. Okay, so number one is venous stasis or stagnation of blood, and that can be caused by immobility. Okay, so if you are immobile, it means then the blood also will not be moving at the same rate, so therefore it can stagnate, and once it stagnates, it clots. Okay, and then patients who have heart failure, they are not able to pump blood well, but because of the heart problem, the blood is not able to come back to the heart as normal. Okay, so the venous return to the heart is compromised, and therefore you end up with stasis, and that stasis basically can cause can result into clotting of that blood. And then obesity. It goes without saying that with obesity, these people are not very active, and therefore it can lead to stasis of blood. The second thing is venous or endothelial injury. Now, when we talk about endothelial injury, we're talking about anything that causes trauma or causes injury to the blood vessels, like a trauma involving a road traffic accident or history of recent surgeries, or for those people who use catheters, especially the patients who are either under dialysis and they have to keep on using those catheters or central lines and all that, okay? Or people who have had previous deep venous thrombosis. Okay, and then with the third aspect is hypercoagulability. So there are some certain conditions that basically make your blood a bit thicker and make it more prone to clot. Number one is pregnancy, okay, or patients who are suffering from cancer, or patients who are using oral contraceptives, or even inherited thrombophilias. Now, what is the pathophysiology? So first, you have either stasis or stagnation of blood, or an injury to the blood vessels, or any condition that causes your blood to be hypercoagulable. So that basically will lead to formation of a clot. Now, this clot can either be a complete clot, whereby it occludes or it blocks the blood vessels completely, or it can be a partial clot, which basically allows some of the blood to keep on to pass through. Okay, now when it completely obstructs, it can actually, a fragment of it can dislodge, and then it can be pumped to the lung, to the heart first, and then from the heart it can be pumped to the lungs, and once it goes to the lungs, it can actually cause what we call, it blocks the blood vessels in the lungs, and it can cause what we call pulmonary thromboembolism. Now, how do patients present? So they will present with swelling, pain, warmness, redness, and heaviness of either the affected area, mostly either around the thigh region and also around the calf region, okay, or the calf muscles, or even around the hip region. Now, they will also present with a unilateral edematous lower limb, okay, and then when you do the measurement, the calf muscle or even the thigh region, okay, will be more than 3 centimeters more than 3 centimeters when you compare it with the normal lower limb, okay, and then there will also be tenderness. Now, they may be asymptomatic until when a pulmonary embolism takes place. Now, what are some of the complications that you need to be aware? Number one, on the top of the list, which is one of the major complications you don't want it to happen, and it's a medical emergency, is pulmonary thromboembolism. And these patients will present with dyspnea or shortness of breath. They will present with chest pain. They will present with syncope or some fainting attacks, and as well they can actually present with shock. Okay, and then there will be post-thrombotic thrombotic syndrome, which basically is characterized by chronic chest pain, swelling, and development of ulcers that are difficult to basically heal. And then the other complications include recurrent development of deep venous thrombosis. So What are some of the investigations? So number one, you need to have high suspicion of deep venous thrombosis. So there is a criteria that we normally use called the Wells score. Now, Wells score, basically, we are looking at the symptoms, okay, and then physical examination as well as tests that you can do, and you can basically grade from severe, moderate, and low risk. Okay, and then after that, you can also do some other tests like D-dimer, which is very sensitive but not specific. Now, D-dimer basically is a protein that is produced as a result of a clot dissolving. So once the clot dissolves, it produces this protein called D-dimer. So what we mean when we say it is sensitive but not specific, it means then once you test negative for the dimer, it means that high chances, almost 100%, this patient does not have DVT. But if the dimer tests positive, okay, it means that the probability of this patient having DVT is very high, but it doesn't mean that he or she has DVT. Okay, so if the dimer is negative, then you probably need to think about another cause of the symptoms this patient is presenting. But if the dimer is positive, now you can go ahead and do some other tests that will be able to confirm your diagnosis. Another test that you can do is a Doppler or a duplex ultrasound, which is basically the first line test. Okay, you can also do other tests, especially if duplex ultrasound is not very conclusive and you still have high index of suspicion that this patient might be having deep venous thrombosis. You can go ahead and do venography, but of course, venography is more of an invasive procedure. So you can do CT or even MR venography, which may be able to shed more light on and help you to make a conclusive diagnosis. Now, how do we manage these patients? So once you have done your test, you have made your diagnosis, how do you manage? So you can grade these patients according to the severity. So if they are stable, their heart rate is okay, you need to encourage mobilization. Once you have given anticoagulants and you have reached your reached, okay, your anticoagulation state. Okay, so elevate the limb and then you can give compression stockings. Now, when it comes to medical management, the initial management, you can use low molecular weight heparin, okay, or you can use unfractionated heparin or fundaparinax. For the long term, you can use warfarin, but you need to maintain your INR between 2 to 3, okay? And then, so in the management, we have what we call the provoked DVT and the unprovoked DVT. So the provoked DVT is when you are having something that actually caused the DVT. Like for example, this patient had a previous history of surgery, okay, or this patient basically had a history of trauma, okay. So basically, you have a documented risk factor that contributed to the development of DVT. Okay, so for those patients, you need to treat them for 3 to 6 months. And then for the unprovoked, whereby you don't have a specific risk factor, you need to treat these patients for more than 6 months. Okay, and then there are those patients who basically have cancer. Most of the time, you have to treat them for longer terms. Okay, so other treatment include you can do, especially when you are in a setting where you have all the resources and this patient maybe they are contraindicated to give anticoagulants. You can use what we call intravenous inferior vena cava filter, whereby you put a filter or a sieve at the inferior vena cava to sieve off any clot from getting into the heart, which can easily be pumped to the lungs. You can also do thrombolysis, and thrombectomy. So thrombolysis is basically an invasive procedure where you go and burst the clot, or thrombectomy is where you go ahead and cut and basically remove the clot, especially when you have intensive or massive clots, okay, in the lower limbs. Now, how do you prevent? Number one is early mobilization post-surgery. That's why we advocate patients after surgery, they need to start physiotherapy as soon as possible, okay? And then you can also advise on mechanical prophylaxis like use of compression stockings, especially people who are traveling for very long, okay, or people who are immobilized for quite a long time. They can use compression stocking to be able to increase venous return. And then there are people who people who are bedridden, people who have chronic illness and they have to be bedridden for quite some time. You can prescribe prophylaxis, or like a use of low molecular weight heparin and other drugs that are available in the market to help with prophylaxis. Now, during travel, okay, for patients who are traveling for quite a long duration, okay, or longer journeys, and they have to sit for quite a long time, you can give prophylaxis. But also you can advise them to hydrate more, okay, and basically do some exercise while in their journey. They can also use compression stocking to help reduce the risk of development of DVT. Now, what are some of the patient's advice that you can give, especially for patients you've already made a diagnosis, like for Mrs. Obeku? Okay, number one is you need to advise them to adhere to the medications that you've given to them. Okay, so adherence to anticoagulants is very crucial. Number two is that you need to monitor the INR for warfarin therapy so that it remains always within the normal range, because an elevated INR will mean that these patients are running a risk of bleeding. Okay, and then you need to teach them to recognize signs of bleeding. Okay, so they need to be very careful. They need not to injure themselves. Okay, and then of course you need also to advise them on lifestyle modification. Okay, so they need to to control their weight, so they need to do exercise and reduce their weight. They need to hydrate more, they need to stop smoking, and also they need to be more active. So physical exercise, very important, okay? And also you need to advise them to seek help, especially anytime they see any kind of swelling that looks suspicious, so that they get the right medical care before things escalate. Now, if you have found this lecture very helpful, you can always follow me. You can hit the subscription button so that you are notified every time we post a new video. Until next time,